Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. In this particular session, I will be discussing a very important topic, that is the lung abscess. So, what exactly you mean by this lung abscess? Lung abscess, it is a localized, infectious, suppurative necrosis of the lung tissue. Okay, so it is a localized, infectious, suppurative necrosis of lung tissue. Right, so this is what you mean by this word, the lung abscess. And this localized infectious suppurative necrosis of the lung tissue, it should be of size more than 2 centimeters in diameter. Right, it should be of size more than 2 centimeters in diameter. And what are the predisposing factors for the development of the lung abscess? First and foremost, the very important predisposing factor is the aspiration of the infected material. So this is one of the very important predisposing factor for the development of the lung abscess, that is aspiration of the infected material. And these aspirations, it could be during the oropharyngeal procedures, and this aspiration, it also could be secondary to the dental sepsis, and this aspiration could be because the individual is in the state of coma, or the individual is under the effect of alcohol, or the individual is under the effect of anesthesia. And next, the individual might be in a state of altered sensorium after an episode of the seizure or bulbar palsy. So these are the predisposing factors for the development of the aspiration, and this aspiration can make the individual to land up in the lung abscess. Next, the another important predisposing factor is inadequately treated pneumonia. Right, inadequately treated pneumonia. So that is another important predisposing factor. And third, pulmonary infarction can predispose to the development of the lung abscess. And fourth, septic emboli to the lung. These are the predisposing factors for the development of the lung abscess. Now, after having discussed about what are the predisposing factors and what is the definition of the lung abscess, let me tell you some of the characteristic features of the lung abscess. See, this particular abscess, it may vary in size and as well as number. Right, it may vary in size and as well as number. And most of the time, the aspiration abscess, right, we have discussed one of the very important predisposing factor is the aspiration. So the aspiration abscess, it is more common on the right side. Right, it is more common on the right side. Now the question is why this aspiration abscess is more common on the right side. That is because of the more vertical right bronchus. Right, that is because of more vertical right bronchus. Okay, so that is the reason why the aspiration abscess is more common on the right side. And that too, on the right side, which part of the lung on the right side is affected? That is the posterior segment of the right upper lobe. So posterior segment of right upper lobe is the one which is commonly affected and chance of development of the lung abscess, right? Posterior segment of the right upper lobe or the apical segment, right? Or the apical segment are being affected. Now, when the abscess is there for a longer duration of time, that can make the individual to develop what is called chronic abscesses. And these chronic abscesses, they are often surrounded by a reactive fibrous wall. Okay, so the chronic abscesses they are surrounded by a reactive fibrous wall. Okay, so that is what are the characteristic features of the lung abscess. And you need to know what are the common organisms which will cause this lung abscess. So the common organisms which causes this lung abscess, they include anaerobes, then next Staphylococci, next Pseudomonas, Legionella, and this particular Legionella is the organism which is responsible for the development of atypical pneumonias. And another important organisms are Mycobacterium tuberculosis, Streptococci, and as well as Nocardia. These are the common organisms which can cause the lung abscess. Then, what will be the clinical features in patients with lung abscess? The clinical features include the development of the high-grade fever, right? The development of a very high-grade fever. Then followed by that, the individual can also have cough with copious amount of expectoration. Right, cough with copious amount of expectoration, and the individual can also have weight loss, right, and there will be also hemoptysis. And when you examine these individuals, right, they can also have clubbing. So these are the clinical manifestations and examination finding in patients with lung abscess. And when you auscultate these patients, you will listen the bronchial breath sounds, and you can also have the presence of creps. So these will be the features of the lung abscess. Then, if you take the chest X-ray, investigations, chest X-ray is very important. So the investigation, what you have to do is the chest X-ray. So the chest X-ray, it will show you the presence of the lung abscess, and what is that you will be able to make out in the chest X-ray is the lung abscess, it appears as a thick-walled solitary cavity, right? A thick-walled solitary cavity. That is what you will observe in the chest X-ray. And this thick-walled solitary cavity is surrounded by a strip of consolidation, right, surrounded by a strip of consolidation. And within the lung abscess, there can be also presence of the air fluid level, right? So you can make out a slight air fluid level here. Okay, and what are the other causes of the cavitary lung disease? See, in case of your lung abscess, you have the presence of thick-walled solitary cavity. But what are the other conditions where you have the presence of the cavity? You can have that in patients with tuberculosis. You can have that in patients with malignancy, right? And you can have that in mycosis, that is fungal infections, right? And you can have that in patients with pulmonary infarction, right? And you also have that in Wegener's granulomatosis with polyangiitis, right? So these are all the conditions where you can have the presence of cavity. Next, now you take in case of necrotizing pneumonia, right? So necrotizing pneumonia also, you have the consolidation of the lung or necrosis of the greater part of the lung. But how will you distinguish the necrotizing pneumonia from the lung abscess? See, in case of the necrotizing pneumonia, the chest X-ray shows multiple areas of cavitation, right? Shows multiple areas of multiple areas of cavitation within an area of consolidation, right? Within an right, so there are multiple areas of cavitation within an area of consolidation. That is what you will have in necrotizing pneumonia, and by which you can differentiate that from lung abscess. Whereas you take in case of empyema, it is characterized by the presence of the purulent pleural fluid, and it may accompany either of other. So in necrotizing pneumonia, you will differentiate that from lung abscess by multiple areas of cavitation with an area of consolidation. Next important investigation is the ultrasonography. What is the use of this ultrasonography? It helps in localizing, right? It helps in localizing where exactly is the presence of the fluid, and it may also reveal the pleural loculations. Right, it may also reveal the presence of the pleural loculations. That is what you will observe in the ultrasonography. And next important investigation is the sputum examination and as well as culture. So by doing this sputum examination and culture, you will be able to make out what is the organism, and you will also be able to make out the sensitivity of that particular organism. So culture and sensitivity can be done by the sputum examination and as well as the culture. And another investigation is the rigid bronchoscopy. Now what is the purpose of this rigid bronchoscopy? Rigid bronchoscopy is done for adequate suction, right? And this adequate suction of the secretions from bronchial tree, that helps in clearing the airway, wherein the exchange of gases and passage of air occurs adequately. And please remember, what you have to use is the rigid bronchoscopy, right? So this rigid bronchoscopy is used in case of the lung abscess for adequate suction of secretion from the bronchial tree, whereas this fiber optic bronchoscopy, this should be avoided, right? This should be avoided. Why? As the suction channel is small and the flood of pus may drown the patient. So usually the fiber optic bronchoscope should be avoided because the suction channel in fiber optic bronchoscopy is small. Okay, next, then followed by that, how do you manage, that is, how do you treat these patients? Definitely the appropriate antibiotics has to be given. And what will be the medication of choice in case of lung abscess? You need to give clindamycin, and along with this clindamycin, you also have to add amoxicillin clavulinate. Right, clindamycin plus amoxicillin clavulinate. And what should be the dosage of this clindamycin? That is around 600 milligrams of clindamycin should be given intravenously, and that has to be given every 8th hourly. Right, that has to be given every 8th hourly until the improvement occurs. Then once the improvement is there, you need to switch over to 300 milligrams of clindamycin, and this 300 milligrams should be given orally, and this has to be given every 6 hours. Right, this has to be given every 6 hours. So that is about the dosage of your clindamycin. Whereas amoxicillin clavulinate, if you see, the dosage of amoxicillin that you need to give is 875 milligrams, and clavulinate, it should be 125 milligrams, and this has to be given orally. And how frequently you give? That is every 12th hourly, and you have to give this until the improvement occurs. Okay, now we have also another combination, that is, right, that is penicillin. Right, and this penicillin, it is in the form of the amoxicillin or penicillin G. This penicillin should be added to metronidazole. Right, should be added to the metronidazole, and this combination, it is always a second line opinion. First line will be always clindamycin plus amoxicillin clavulinate. Second line will be your penicillin plus metronidazole, and this penicillin, it is in the form of amoxicillin or injectable form, that is penicillin G. And always remember, penicillin alone is inadequate. Why? For anaerobic pleuropulmonary infections, you have these anaerobic organisms that produces beta-lactamases. That beta-lactamases will break the beta-lactam ring of the penicillin, and thereby the efficacy of the penicillin is reduced. And that is the reason why this penicillin always should be added along with the clavulinate, right, which is a beta-lactamase inhibitor. And if you see the duration of therapy, antibiotic therapy for this lung abscess or for anaerobic pneumonia should be continued until the chest radiograph improves. Right, so until the chest radiograph improves, you have to give this antibiotic therapy. Okay, and the other point is that patients with lung abscess have traditionally been treated until the resolution of the abscess cavity is demonstrated by this chest radiograph. Next, followed by that, what is the indications of the tube thoracostomy? Mainly in case of anaerobic pleuropulmonary diseases. Right, so anaerobic pleuropulmonary diseases, they require adequate drainage with tube thoracostomy for the treatment of the empyema. Right, and next important point, open pleural drainage is sometimes necessary because of propensity of these infections to produce loculations in the pleural space. So whenever there is formation of loculations that is the point when you need to do open pleural drainage. Okay, and this is your chest tube. Then another important step in the treatment is the physiotherapy and as well as the postural drainage. This physiotherapy and as well as postural drainage that helps in clearing the airways. Right, that helps in clearing the airways from the secretions, from the abscess. So your physiotherapy and postural drainage is also very, very important. Then what are the indications for surgery? For suppose, if there is failure of medical therapy, right, if there is failure of medical management in spite of bronchoscopic clearance, surgical resection is advised. Okay, in spite of doing bronchoscopic clearance, still there is disease present, then you need to do the surgical resection. And next thing is, presence of obstructing carcinoma is an indication for surgery. Right, presence of the obstructing carcinoma is an indication for surgery in addition to the definitive management according to the staging and general condition of the patient. So this is about the indications for surgery. So let me just revise or recap the lung abscess in a very short manner. So when will you use this terminology called lung abscess? Lung abscess, it should be a necrotic lung tissue where you have the infectious material in that particular necrotic lung tissue, and the size should be more than 2 centimeters in diameter. Predisposing factors are aspiration of the infected material, inadequately treated pneumonia, pulmonary infarction and septic emboli. The characteristic features is that these abscess, they vary size and number, most commonly on the right side. Why? Because the bronchus on the right side is vertical, and that too on the right side, the posterior segment of the right upper lobe or the apical segment of either lower lobes are commonly affected. And in case of chronic abscesses, like you have the reactive fibrous wall, and the common organisms are staph, strep, Pseudomonas, Mycobacterium tuberculosis, Legionella and as well as nocardia. And clinical features: very high grade fever, cough with copious amount of expectoration, weight loss, hemoptysis and clubbing. And chest X-ray will show you the presence of thick walled solitary cavity surrounded by consolidation, and you also have the presence of the air fluid level. And ultrasonography is of value in localizing the or in locating the fluid, and it also reveals the pleural loculations if they are present. And sputum examination and culture will help us in making out the culture and sensitivity of the organism. Rigid bronchoscopy for adequate section of the secretion from the bronchial. Management is like you need to give appropriate antibiotics. Mainly the medication of choice will be clindamycin. Along with that, amoxicillin clavulinate should be given. And second line will be your penicillin. Along with that, metronidazole should be given. And the duration of antibiotic therapy is until the chest X-ray shows the resolution, you have to give this antibiotic therapy. And indications of tube thoracostomy is like mainly anaerobic pleuropulmonary disease. They require adequate drainage with tube thoracostomy for the treatment of the empyema. And physiotherapy and the chest drainage is also very important. And indications for surgery is that if there is failure of medical therapy in spite of bronchoscopic clearance, surgical resection is advised. So this is about the topic related to your lung abscess. Thank you very much.